Thank you so much for having me here today to speak to the future of American medicine. I'm so happy to be speaking to young hearts and young minds about an issue that's very near and dear to us all in our country right now, which is the diagnosis and treatment of our returning veterans from Iraq and Afghanistan who have suffered traumatic brain injury. What I'd like to do today is just to introduce you all to the many characteristics of traumatic brain injury, some of the treatments, so that you will be the experts when you all get out in diagnosing and treating this very important injury in our nearly 2 million veterans who have now served in both Iraq and Afghanistan. One of the things I found out when I began treating our veterans is that every war seems to have its own injuries, its own technologies, the illnesses associated with it. And so you have to almost treat every war, physicians do, as having its own personality. And physicians, both those within the Department of Defense, DoD, the Veterans Administration Hospital, VA, and the civilian world, need to be astute as to what kind of injuries and illnesses and medications our soldiers may be taking when they return. So when I began looking a little bit at Vietnam, we all know that Agent Orange was the major issue there. It really wasn't recognized for about 20 to 30 years post-war, but by that time there had been enough data that had been collected showing that it caused things such as diabetes and neuropathy and, of course, cancer and very many lymphomas and sarcomas and cancers that we didn't normally see in a younger population. The medicine of choice, the self-medication of choice in the Vietnam veterans were downers, mainly marijuana and alcohol, kind of drowning out what was going on around them in the jungles of Vietnam. And so when we went to the Gulf War, we began noticing that there was a problem with ALS, or amyotrophic lateral sclerosis. The incidence of ALS in our Gulf War veterans is about 1.6 times the general population. The etiology is felt to be either the neurotoxins they were exposed to or the medications that we gave them to protect them from those neurotoxins, or a combination of both. So if you see an individual who has come from the Gulf War and is complaining of weakness without any sensory loss, unfortunately you had better be thinking ALS. Dr. Ann McKee, who you all need to look up in Boston, she's the woman who has done all of the chronic traumatic encephalopathy, or CTE, kind of studies for the NFL, is noticing that these young men, primarily young men fighter pilots and some women fighter pilots from the Gulf War, have what's called the chronic traumatic myeloencephalopathy, or the ALS, which she now attributes to kind of continued cumulative brain injuries. And for the fighter pilots, it was the brain injury sustained when they took off, and the snapping back of the head, which affected both the posterior part, the occipital lobe, as well as the spinal cord in those areas. So if we move on to these wars, OIF, or Operation Iraqi Freedom, and OEF, Operation Enduring Freedom, the war in Afghanistan, we know that traumatic brain injury is the signature wound of these wars. Also, many of the individuals from these wars have multiple amputations, and they have that because the armor that we have now is superior to the armor in previous wars, and so that the individuals will actually live through the explosion but suffer the loss of multiple limbs. They also will suffer difficulties with a traumatic brain injury. The signature of these wars then is the traumatic brain injury, or TBI, post-traumatic stress, or PTS, formerly known as post-traumatic stress disorder, but we'll talk about that in a few minutes. We're kind of on the cutting edge, referring to it as post-traumatic stress, or a mixed syndrome of both traumatic brain injury and PTS. The drugs of choice in our heroes returning from Iraq and Afghanistan are uppers, of course, because never before have we been in a war that stay awake, stay alive has been more important. And it's very important for them to be alert and oriented at all times. Hence the use of methamphetamines, caffeine, and even cocaine to stay alert and stay alive. So many of our individuals, when they come back, are very hyper, not just from the experience, not just from the brain injury, but from the self-medication with amphetamines and uppers as well. In March of 2009, we claimed that traumatic brain injury was the hallmark pathology of this war. And the triad, or the difficult triad, or terrible triad for this war, is a combination of traumatic brain injury, post-traumatic stress, and pain. And that is of the three different conflicts that we're talking about now: Operation Iraqi Freedom, Operation New Dawn, which is the acronym given to the individuals between September and December of last year when they started the pullout in Iraq, and then the Operation Enduring Freedom. It is felt that 20 to 25% of all individuals who served in these wars, and there's 2 million who've served in Iraq and Afghanistan, have suffered a traumatic brain injury. 20 to 25% equates to about 500,000 young men and women in our country right now who have returned from these wars who are suffering from a mild traumatic brain injury. These are caused primarily by blast injuries, and you'll see a lot of acronyms throughout this talk. Look them up on armyacronyms.com if I don't go through them well enough for you. But they're used routinely, and if you're taking care of a soldier, you're taking care of a warrior, you're taking care of a member of the family, it will really increase your ability to relate with them if you know these terms. One is the IED, or improvised explosive device, and that's what we've been seeing and reading about, the roadside bombs that explode, the vehicle gets turned over, the individuals are injured from those blasts. RPG is rocket-propelled grenade, and I'm sure you've seen that on YouTube and on the different movies that have been where they can shoot the grenade and it comes soaring across the sky and then hits an area, hopefully not a person, but that also, if you're standing within like a 50 to 100-yard radius, you can suffer a traumatic brain injury. And then there's the difficult with vehicular accidents. We now have the MRAP, which is the mine-resistant, ambush-protected, but at the beginning of these wars, and I mean for the first 5 years of these wars, we were using Humvees that were turning over frequently on the incredible difficult terrain in both Iraq and Afghanistan, Afghanistan being the most difficult, as I'm sure you would understand. So falls on these terrains are also quite common and have accounted for many traumatic brain injuries. And the last area that I kind of recall are the individuals who have been injured by hitting their heads on their way out of the barracks for a night raid. We know that traumatic brain injury, when it's particularly with the triad of post-traumatic stress and pain, leads to an increase in suicide. And I know when you're in medical school, it's really difficult to keep track of the news, but you guys are so much better because you have, your iPads and your iPads and your iPhones, and you can keep up with these things, that you know that the suicide rate among both the military and our returning veterans is the highest that it's been in 2 decades. In fact, and this is the part I want you all to remember, because these are young men and women your age, this is your generation, who are killing themselves at the rate, by their own hands, of 1 every 36 hours. That's a tremendous suicide rate, and we definitely need to do something about that. The National Guard and reservists are not even included in this particular statistics, so we know that they're even a lot higher than that. And throughout all wars, every day in this country, 18 of our veterans will die by their own hands. The suicide methods, of course, firearms being number one. This is a group that's very well skilled in utilizing firearms. Overdose is the second thing that we often will see, and that's an overdose usually with pain medications, OxyContin, that we'll talk about just in a few moments here. And then the third are motor vehicle accidents. And these could be motor vehicle accidents with motorcycles, with all-terrain vehicles, with fast cars. This is an adrenaline-pushed generation. You all are. And then when you put a soldier in a war zone where the adrenaline is pushed even much more to the limits, and then you deploy them several times, you could see how their whole world experience becomes one of a very hypervigilant, hyperadrenaline state. So many of the cases of accidents and risk-taking behavior, such as jumping out of airplanes and all of that, are actually felt to be suicides but not proved. When we discuss what is the brain syndrome of these returning heroes, we have to talk about TBI versus concussion. And, in physicians who are taking care of individuals, either in the sports world or in the military world, the term concussion is not utilized very much anymore. So you can be on the cutting edge of your professors if, you bring that up. We don't really use concussion anymore. It used to be the concussion was kind of coming from an exterior type of injury, a blow to a particular area of the head, whereas the traumatic brain injury from the blast is a full brain explosion of sorts. It doesn't just hit one particular area of the brain and perhaps the contracrue lesion on the other side, but the entire brain is affected. So the blast injury leads to DAI, or diffuse axonal injury, where the axons for those little nerve cells are just torn apart in a very fragmented area. Since every brain is different, every blast is different, every distance from the blast is different, every individual of those 500,000 will have a slightly different traumatic brain injury. And that's one of the difficulties we have right now in treating these individuals who are coming back. You have to be somebody who really, really likes to explore and really likes to have protocols that you yourself can make with the patient. It requires the most, contact between patient and physician of any injury that you will see. Okay, it takes a lot to get a brain back, and you are, in many instances, the person's contact with the new normal or the new world that they will be experiencing when they are able to adjust. What I want to point out here is that the playing field injury then is not the same as a blast injury. The blast injury is felt to be much more severe, and in many cases up to 1,000 times more severe than one single injury on the playing field. But because individuals are playing sports, they get the accumulative problem with the repeated concussion-like injuries, and the same is true for our military. They get repeated difficulties with the traumatic brain injury, with the blast injury. So what are some of the hallmarks? And I will tell you guys, only 8 to 10% of all physicians in this country even deal with traumatic brain injury. So you will be on the cutting edge if you look at this lecture and say, man, this is something I really want to do. And I really encourage you to do it because the brain is the only organ that we really haven't defined very well. And it is the decade of defining the brain now that we have such good neurodiagnostic images that we can reflect upon. Sensory processing alterations are very common, and the first I'll bring up is photophobia. If you have a young veteran or military person coming to see you from Iraq or Afghanistan, and they walk in your room with really dark reflector sunglasses, think traumatic brain injury. There is nothing like a TBI to keep you from being able to filter out light. So if you think of these individuals being in the land of what they call the eternal sun, and then undergoing a traumatic brain injury and not being able to filter out that sun, you can see that their fear of light, photophobia, their difficulties with light, particularly fluorescent lights, is one of the hallmarks, and in fact the hallmark, I believe, next to headaches in a traumatic brain injury. The second thing that happens is they get hyperacusis, or sounds are a lot louder to them. And if you think about it, when their brain has been damaged, this is kind of the body's survival mechanism. The brain isn't thinking very well, so they're going to make sure that it sees better and hears better. Unfortunately, since the brain can't filter that all out, it becomes disruptive and very hypervigilant and very agitated. So you see the agitation with what we call the big box syndrome, and that is individuals walking into Walmarts or Myers or any of the huge giant mega malls can't stand it. They can't filtrate all of that information. It all comes to them at once, all of the light, all of the noise, all of the people. And if you recall that so many of our soldiers had been involved in kind of not only roadside blasts, but blasts that happen, in the city markets, you can understand their fear and apprehension of being in wide open spaces, football games or sports events. So that's another hallmark. If you can just quietly ask the individual or their family member, and I always encourage them to bring, their family member or their close relative with them to help decipher, both the history and the instructions that I'm going to give them at the end of the evaluation. There is a loss of mapping skills, and please keep this in mind because it is very, very important. In most of the cases in Iraq and Afghanistan, it is the navigator, the person riding shotgun, who gets injured the most with a traumatic brain injury. Unfortunately, the gunner, the person who is up in the turret, usually gets killed. The driver gets some injury, the navigator usually gets thrown from the vehicle, and the worst, head injury. And you really know that they have a TBI when they were able to navigate the dirt roads and rubble in Iraq and Afghanistan, and they come back to their home in rural Ohio or rural Missouri or rural Kansas, and they can't find their way around. Think traumatic brain injury. So any of those, the sunglasses, the kind of shake with noise, the fact that the person doesn't want to go outside their house to any, all of those are hallmarks of traumatic brain injury. Think of pituitary dysfunction, and we'll talk about that really soon, and chronic headaches as well. When we go to the caffeine content of drinks, let's talk about adding brain insults to injury. And that is that most of our young heroes, while they're in Iraq and Afghanistan, are taking between 10 and 12 energy drinks a day. And I'm not exaggerating. The most that I heard an individual taking was 30. And we're talking about a load of caffeine. Caffeine, unfortunately, impairs the blood glucose utilization in the brain. So it kind of constricts the blood vessels so that the cells that need the glucose to repair themselves cannot get it, because this young individual is now jacked up on caffeine. And again, I know that you're kind of nestled away in your medical school, but just a couple weeks ago there was the 9th person, and now they've declared 15 young individuals who are not associated with the military who have died as a result of ingesting 10 to 12 of these caffeine drinks a day, usually for cardiac arrhythmia. So they are definitely a force to be reckoned with, and something that you need to understand when you're talking about our heroes or when you're examining them. The diagnosis of traumatic brain injury is simple if you listen to the patient. And Sir William Osler, the gentleman who kind of founded our modern medicine in the allopathic world, just said, listen to the patient, he will tell you what is wrong. Traumatic brain injury is primarily noted by history, and it's so important for you to take an accurate history as well as note the manner in which the history is being reported. If there are various pauses, if the individual can't find their words, if they stutter, if they look off to the side and seem to be kind of lost track with their way of thinking, think traumatic brain injury. Watch how they're telling you the story. We are so lucky right now because now we have great windows to the brain. In my day, when I was sitting in your seat, I know you're well in my day, but when I was a medical student, we didn't have anything other than a brain scan that was just kind of coming out at that time, which pretty much showed you if you had widespread metastatic disease to the brain, but not a whole lot else. A few major bleeds, but things had to be really major in order to see it. Then came along in the 1980s, the CAT scan and the MRI, and they are very good techniques. However, the CT scan and the MRI that are standard are routinely negative in somebody with a mild traumatic brain injury. And let me repeat that again. A person with a mild traumatic brain injury will have a negative CT scan and a negative MRI nearly 100% of the time. So that's very important if you decide to become an ER doc. That's very important if you're covering the ER, and very important if you're dealing with any of our soldiers, because these tests will be negative for them, even though they have major deficits with their daily life. It is one of my problems that I have to deal with when an individual comes from the VA, because that is the gold standard at the VA. So if an individual has, for instance, had 5 blast injuries in a tour of duty that ended 3 years ago, and they come into the VA and they're having word-finding problems, they can't balance their checkbook, they can't find their way around their home, and they're told they have a negative MRI, they say, I must be crazy. That's why we're changing that whole term post-traumatic stress disorder to post-traumatic stress. We're actually going to be pointing out here in just a few slides that itself is a brain injury. We now have the gold standard, which is the diffusion tensor imaging, DTI imaging, and that shows the very, very little axon and how it has been bleeding and retracted. You can almost see microscopic changes within the brain, and that is so very important because they're seen in so many different areas, including the frontal lobe, which we all know gives us our executive function. So we have those great diffusion tensor images by Dr. Michael Lipton and some of the great neuroradiologists in the country. We also have the PET and the SPECT scans, and those were primarily utilized by Dr. Havda. Look up Dr. Havda at UCLA. He is the #1 collaborator with the Department of Defense and has done some of the most major research on basic blast type injuries. And then of course we have the functional MRI that tells us what the patient is thinking and where they're thinking it and what parts of the brain are not working. It is so interesting that very, very subtle differences can make a huge difference in the functionality. For instance, the difference in a PET scan or SPECT scan between someone who has a mild traumatic brain injury and somebody who is in coma is about 10%. So it's a very steep drop-off from the time that your brain kind of ceases to function altogether and where it's really, really struggling. Most of our veterans are unfortunately tested 1 to 4 years after they return from their tour of duty, and often 1 to 4 years after their last traumatic brain injury. It is very, very important in a traumatic brain injury to see them, diagnose them, and treat them as soon as possible. Because, you know, the term use it or lose it goes along with the brain as well as any other organ. And if you can't use your brain, you cannot function on your own. In 2013, beginning in January of this year, we're actually going to be doing a study here in Ohio using our Ohio National Guard members who just came through a very brutal tour of duty in Afghanistan where they lost over 4 members, where 19 members were moderately or severely injured from blast injuries primarily in city marketplaces. And so we have an estimated, from the 2,200 who have come back, 500 young men and women who now will have a traumatic brain injury. So we're going to use that pool of individuals, and we're going to get 25 of them and 25 of their age match closest male sibling. And we're going to be testing them at Albert Einstein University with the fusion tensor imaging so that we can see right here, right now, what is the injury, how is that translating over to their function, you know, how does what we see on the screen kind of will go over to what they're doing within their family, within their workplace, you know, so we can tell them, no, you're not out of your minds, you're out of your brains. It's an entirely different concept. We'll be doing neuropsych testing, which, you know, kind of tells us how they're thinking, what their reaction times are. We'll be checking balance and vision and hearing. We'll also be checking their pituitary function, and all of this will be a pilot study to kind of define the brain technology. And you got to shake your heads. You know, we are 11 years into the war in Afghanistan, and, you know, even at that, we are now still trying to define the blast injury. So that's why I think this is such a very, very important lecture, because we need to combine the resources now of the civilian world, which are 99% of the healthcare resources, with the resources of the Army and the Navy, the Department of Defense, and the VA, which are only 1%. And no time has it been more important than now to be able to do so. The hormonal abnormalities, look for them. Okay, have a high index of suspicion of any young man or woman who comes into you who's actually been in the war zone. And technically, the 330,000 women who have served in these wars are not supposed to be in combat. However, we know that routinely they are. They're like refilling vehicles when RPGs come across, or a roadside bomb occurs. So that happens to them as well. But the majority are, of course, the men who are in combat. And you need to look for everything: growth hormone, thyroid stimulating hormone, testosterone, cortisol levels. All of these need to be looked at, because I cannot tell you how many of my young men, it's only been about 3 or 4, but these are young men who have been told they were depressed, who were given antidepressants, who were actually losing muscle mass when I saw them, who had virtually no pituitary function. And I've got to tell you, all 4 of those young individuals have said to the team of doctors that were taking care of them, who found the pituitary problem, you know, thank you for giving me my life back. Have a high index of suspicion. If somebody says that there's a problem, believe them. Don't think that they're out of their mind to begin with. Do not miss the opportunity of curing somebody of a pan-hypopituitary problem. You know, remember, these are young people in their 20s. They've got a long life ahead of them, and you've got to make sure that that pituitary function is monitored throughout their lifetime. The neuropsych testing takes a while. It's very frustrating to many of our soldiers who are returning, because it points out the deficits. You know, they can't remember things that they knew they used to remember. They read some sentences and they can't remember it. I just kind of try to instill a little bit of hope with them, because fortunately I had my own traumatic brain injury in 1999, and that's one of the reasons why I'm so passionate for them. At that point in time, my MRI, my CT scan were also normal, and I couldn't speak for 6 weeks. And I had no feeling over the right side of my body, and I couldn't drive for a couple months, and I couldn't negotiate a left-hand tour for 6 months. I was not making it up. If I didn't work, I didn't get paid. You know, it's not like we're trying to be litigious. I had nobody to sue. I had the big box theory, and I had hypervigilance, and I didn't want to go in crowds. And I can tell you, I didn't have post-traumatic stress disorder. I had a traumatic brain disorder. Mine all occurred while I was putting up Christmas decorations. So it was with these kinds of stories from both my heroes, from myself, from my colleagues. I have several colleagues here at Memorial Hospital who have suffered concussive-like injuries, who can all attest to the same thing. You know, you really need to be hypervigilant when you are talking to the patient and notice those subtle deficits. Most of the mild traumatic brain injury people won't show memory problems for long term, But if you ask them to remember something that happened at the beginning of, this lecture, for instance, they wouldn't be able to do it. And it's that laying down of new memory that gets in their way. And since they have a great time remembering the old memories, particularly the life-saving memories, like the last thing that kept them alive, like the blast that took out their buddy or a couple of their comrades, that's what they keep playing over and over in their brain because they can't lay down new memory. That is not being out of their mind. They are out of their brain. And we are now discovering that in various brain imaging techniques to prove that that's what's going on. Many of our soldiers, we don't have a baseline. So it's not like in sports where, you have to have the impact test before you even play before the season, and then after, if there's some concussive moment or a traumatic brain injury moment in the game, you have to be compared against your opponent. We don't have that for our soldiers. We need to get that in the future. And definitely people with more significant injuries, people who say they had a loss of consciousness or they didn't remember for a couple days, have a high index of suspicion. But do know that you don't have to have a loss of consciousness in order to have a TBI. The impact test is my favorite of all the tests that are mentioned there on the bottom of the slide, and that's the one that's used most frequently in sports. So we have a new name and a new outlook. Post-traumatic stress disorder is now post-traumatic stress, or PTS, okay? I kind of use both terms within this lecture to kind of get you used to the fact of knowing about both, but from now on, you're going to be the experts and you're going to say that post-traumatic stress, PTS. Formerly, this was called, shell shock or soldier's heart, or a lot of euphemisms. What the real problem was back in World War I and World War II and Vietnam were the blast injuries, the mortar injuries, the shelling that goes on all day and all night long. It caused real dramatic events. And if you all have ever seen some of the old war movies where they show somebody with shell shock and they're shaking there, what are you thinking? You're thinking Parkinson's. Exactly. The basal ganglia is what's being destroyed here, and you need to look at that, and that is what is showing up as having injuries, when we do the diffusion tensor imaging. And the thing that's so important for these young heroes is that they're going to be at risk of developing Parkinsonism by the time that they're in their 30s and 40s. So, when you develop this relationship, know that it's going to be a long-term relationship, and you are going to be the person who is going to help this gentleman, this woman who said, I'll serve, I'll take care of your right to practice medicine, I'll take care of your rights to freedom, but in return, we need to take care of them. We know that there's two routes for processing danger. We've got, our cerebral function, our executive function, and then we've got the fight or flight function, which is there deep in the brain, the basal ganglia, get going. And you all know these slides from your basic anatomy. I'm just going to go over them a little bit so that you can understand that there are definite advantages to what we call that subcortical fight or flight. You don't need to think about it. Let me tell you, if an RPG, if you hear the sound of that RPG coming for you, you have a few milliseconds to get down, to get covered, to get your buddy out of the way, to try to figure out where it's coming from. You don't have the luxury of getting out a slide rule or getting out your iPhone and trying to figure out the trajectory and where's. You don't have that. That is why in war, the subcortical method is actually the method of the survivor. And if that hypervigilant method is what has kept you alive, do you really think that after a 36-hour plane flight from Afghanistan, you can be plopped into your rural community in Kansas or California or Texas and be normal? Pretty impossible, right? These individuals spend days, weeks, months, or even years looking for the enemy and trying to tone down that particular system. We know that the thought process, that cortical method, it does give you time to process and think and rationalize. But the truth is, in war, you don't have that. That may be a luxury for the colonels, the generals, the people who are at the forward operating base or the FOB who are looking things over and have time. But if you're out there in the trenches, you do not have that luxury. So we have this increased arousal that, after all, kept these individuals alive. It leads to things like outbursts of anger or difficulty falling asleep and definite difficulty staying asleep. And that exaggerated startle response if somebody comes in the room. You will notice that many of our heroes, when they return, if they come and they're evaluated, they'll pick a place in your office that is up against a wall where they can see a door, because they are always thinking of that escape. And keep that in mind. And when you see that, thank that soldier for their combat experience, because that truly proves that they were in combat, and thank them for that ability and tell them you're there to help them get over that. We know that suicide is the second leading cause of death in the military, and it's fast approaching the first. And in some months, it is actually the amount of our heroes in the military who have died by suicide has been greater than the amount who have died in war. And what does that say about us? That says that we are not really doing a good idea of helping our military reintegrate into the civilian world. And that's why I find this so challenging. And that's why you have like an open book and the opportunity right now to make a difference in these individuals' lives, all 2 million of them, and not just for now, but for the rest of their lives. And that makes a difference in their spouse and their parents and their brothers and their sisters and their children. So please kind of take this as a challenge, something that you really can be on the cutting edge, because nobody in medical, schools behind you have ever been able to do this. The thing that's most important on this slide that I'm going to ask you to take a look at is, and it was a startling thing to me, that many of the suicides had seen a healthcare provider within 30 days. So that means that we need to have a better sense of awareness and not be so cavalier. If somebody comes into your office and says, today I just didn't even feel like coming here. Or today I was just thinking, if I was hit by a truck or something, what difference would it make? Pay attention to those subtle changes. And please pay attention to the fact that if somebody has had a suicide attempt in the past, as much as they try to downplay it, that's a red flag and a warning sign, because 19% of patients who commit suicide have attempted in the past. A recent, and very recent, in October of 2012, in New Orleans, they presented a paper showing that many of the individuals who develop post-traumatic stress, not just in war, but in other things that happened to them in life, were actually abused as children. And the link that they have shown to that are micro head injuries while they were abused as a child, the shaken baby syndrome, or the baby who was dropped, or the baby who had a broken femur. What they're showing is that many of these individuals from broken homes and from difficult situations like that, of course, volunteer for our military. It's not the billionaires' kids, it's not the doctors' kids or the lawyers' kids who are volunteering to save us. It is the people who are from, kind of lower socioeconomic areas where there are no chances for them for employment or education. And it's not that they are the only areas who have had difficulties with child abuse, but also just with falls and with less parenting, with less ability to parent. So we have to keep that in mind too. And it explains why in individuals who develop a head injury, then on top of it, they develop a form of post-traumatic stress. It's recurrent microtrauma and axonal injury. A book that's really good to read, if you all can, at some point in time in your career, is Why People Die by Suicide, by a gentleman by the name of Dr. Thomas Joyner, and he is another consultant for the DoD. And what he says is that 3 things are necessary for somebody to commit suicide. They have to be capable of doing it, okay? And I bring this up only because our Gulf War veterans who die of ALS have to do so if they want to commit suicide before they lose their ability to commit suicide. And I know that sounds horrible, but it's actually something that is going through some of the military ranks there, because our young guys from the Gulf War are dying from ALS within 6 months of the diagnosis, as opposed to 2 years in the civilian population. So they must be capable, they must desire to do so. And the third most important factor is they must have a feeling of being a burden. They must feel like they're a burden. And that is the one variable that all of us can make a difference. Everybody within the community, and certainly every healthcare provider who sees a soldier, a military personnel, a veteran, has the ability to let them know they're not a burden. They are, after all, service personnel. Their whole goal is to serve. So when you bring them back here and you say, go sit in the corner there, soldier, thank you very much, but we can't really figure out what's wrong with you, so you're going to need to sit over there because we can't employ you, and we certainly can't educate you, we're not sure what to do with you. That's when they become a burden, or they feel a burden to their family, because they can't remember new things. A spouse gives them a list to go to the grocery store. They can't even remember the list, let alone anything that's on it. That feeling of burdensome is what gets to our young heroes when they return. So we now have known, you're already now more educated than about 90% of the physicians in this country, because you know that traumatic brain injury and post-traumatic stress are very close to each other and represent brain injuries in areas in the brain where there's difficulties. For post-traumatic stress, we've noticed that there's kind of a chemical reverberation, a chemical replay of adrenaline substances, a cortisol depletion, so that somebody kind of keeps remembering the same thing over and over again while they're unable to lay down new memory. And that's why cognitive retraining is so important, because you make them try and try and try to lay down new memory until those pathways build up again. One of the reasons why I'm so happy to be speaking to the osteopathic medical schools today is because, by and large, you are much more holistic thinkers than my allopathic colleagues, and definitely those that are in my age group, the middle age group. But holistic thinking is very important. You must move their mind, their body, and their soul, and engage all of it in order to bring the soldier back, in order to bring back this brain injury. We know that if they have psychological factors, that leads to keeping the traumatic brain injury from healing, and the traumatic brain injury plays on the psychologic factors. So it's up to you to figure out what you can do to break that cycle within each individual patient. And keep that in mind. Each protocol here, each recovery will be on an individual basis. And that's what makes this so exciting. That's what combines the science of medicine with the art of medicine. And unfortunately, the art is what we've forgotten. So the symptoms that are most consistent with post-traumatic stress are the flashbacks, the nightmares that keep replaying the same thing, and the exaggerated startle response. But many of those are also seen in the hallmarks of the traumatic brain injury. But keep in mind, those people have difficulties with the photophobia and the hyperacusis, and difficulties finding their way around with mapping. So kind of keep those on a little flashcard if you can, if you're looking at these so that you can kind of, during your history, kind of flip from one to the other and try to see which one is affecting this particular hero more. We have treatment options for traumatic brain injury, and I've got to say that the processing is most important. And let's bring that up again. Processing is most important. Laying down new memory is most important. So you don't really want to slam the brain with all the psychotropic drugs that we have out there. And in fact, the psychotropic drugs are leading to more suicides and leading to more individuals, just being retracted in their own hometown or in their own basement and not leaving. You've got to charge up the brain. So we use things like the Simitrel, the methylphenidate. We've got to get the brain going. If the brain is too hypervigilant, we can use propranolol. We can use amitriptyline. And let me tell you this secret, and this is a secret noted by many, many of us who take care of traumatic brain injury. Old drugs are better than new drugs. Let me say that again. Old drugs are better than new drugs when it comes to the traumatic brain injury. That is, propranolol beats out atenolol. The first generation beats out the third generation. And the same is true for the serotonin uptake inhibitors. Amitriptyline beats out the new ones, although we have many of the new ones that are used as the psychotropic drugs. I want you to get away from those. If you believe that somebody needs a psychotropic drug, what they need is counseling. What they need is exercise. What they need is a holistic way of dealing with this and not snowing their brain. Do not put a brain that's trying to recover to sleep, okay? Most important lesson you can learn. We have great electronic aids, and you guys are just much better at those electronic aids than I am. I'm using my little iPad here so I can figure out where my slides are, but it took me several one-to-ones to know that. You guys can pick it up right away. Have them use their iPad or their iPhone or their SmartPad or their GPS, because if they lose their mapping skills, they can use these electronic aids to get them where they need to be. Their scheduling, all of the above. Text your patients when their appointment is. Don't leave them a voicemail. Most of my young heroes never pick up voicemail, but they'll pick up a text. You have to adjust to the patient population. Pain management, as much as possible, avoid opiates. Exercise is so important. Osteopathic manipulative therapy is important. It moves the body and gets the body knowing where it's supposed to be in space and time, something that hasn't happened for a long time if you've had a TBI. We know that there is education available, and we know that our service members do best if they're allowed to become educated with their own. So there are certain things called the SERVE programs, or the supportive education for the returning veteran, at 18 higher education places throughout the United States, and that's not many, but hopefully we'll gain more, where they're able to attend class with service members only for the first year. So they no longer worry that somebody who's got a backpack may have a roadside bomb. They're not really worried that somebody who comes in late and is all disheveled and, is kind of high from the night before, because that won't, by and large, happen within the military. So those are some things to keep in mind. Exercise, we have to be cautious right after the traumatic brain injury, but aerobic exercise and keeping them going is really, really important. And some of you all, since you're a lot younger than I, are maybe used to 2-hour routines. Keep in mind that some of our soldiers I've now put through, after they recover from their brain injury, 4-hour aerobic routines. 2 hours, quick break, 2 hours more. And this is something that is done a lot by the Marines at Camp Pendleton in California. So they are a new breed, a different breed. It may take much more. They may wear you out, but just develop the exact amount of exercise that is best for them. Get some family counseling. Have them bring their spouse or their significant other with them. Have them bring their kids with them. Make sure that they get adequate sleep. All of these are very important, trying to get their life back. We know that the TBI team and the post-traumatic stress team will require physical medicine specialists and psychologists, occupational therapists, speech therapists, physical therapists, a whole team approach. And it takes the team working on their own individual areas and then the person working on them as a whole to bring them back to what we often call the new normal. They may have lost their ability to balance their checkbook, but we can bring them back to a way that they can work around it using an electronic device to do so. Team approach is so important. Here's those psychotropic medications. Keep them off, okay? Keep them off as much as possible. And the fact that so many of them are on multiple medications from a couple different doctors is unconscionable. We need to stop that. We know that it's detrimental to the recovery of traumatic brain injury. We know that it has been connected to suicide. We know that it's been connected to aberrant behaviors. And in fact, the Sergeant Bales incident of the massacre in Afghanistan may have been connected to those particular medications. And we know that they are also associated with sudden cardiac death, usually in sleep, of our military members. When it comes to pain medications, stay away from OxyContin. It is either 3 times more addictive than heroin or 30 times more addictive than heroin, depending on what you read. In my personal experience, 30 times is closer than 3. It is not the drug of choice for pain. And these guys and gals do not want to be on pain medications. They weren't on it when they went into the military. Keep them off. And again, use the holistic, use the exercise in order to get them off that. More military members are medicated today than ever before. And many of them, because of their long tours of duty, are given hundreds of the medications when they leave here. That's something that the DoD, the Department of Defense, is trying to change, and we need to change it on the civilian world as well. This is one of my favorite quotations when it comes to the military, and that's Will Rogers when he said, "We can't all be heroes because somebody has to sit on the curb and applaud when they go by." And my challenge to you all, since you are going to be the leaders, you are the future physicians, you are the people who are going to bring them out of this horrible brain that they've been left with, I'm going to ask you not to just applaud, but to get off the curb and walk with them and realize that your journey together is going to be long, but it's also going to be very rewarding. And you're going to need to bring the family members in with you when you do it. We need healthcare providers to get involved by taking TRICARE. We need physician clinics to be set up with sliding scales, $5, $10, $25 for a visit, because one thing is true about your military. They will not come see you if they cannot pay. So if they are unemployed, they don't have insurance. If they are 50 miles from a VA and gasoline is $4 a gallon and they don't own a car, they can't get to the Veterans Administration hospital either. But in their own hometowns, if there was a half a day a month or a day a month where physicians could get together, and perhaps you all could start something like this, a veterans clinic at your own medical schools, that would be a great way of capturing them and keeping them close to home and getting them some services. So be vigilant in your particular community and see what's going on and see that our veterans and our military get the services that they need. That's why the VA must join with the civilian world in order to help. We have lots of resources here. The Defense Center of Excellence is one, the Department of Veterans Administration, and I'm talking about our particular organization, the Resurrecting Lives organization, as being one of those. We are a nonprofit that just recently established here in Ohio, but we are going national, that is very narrow and deep. Our goal is to diagnose the exact injury involved in the traumatic brain injury from our Iraq and Afghanistan veterans, and to define the protocols necessary to retreat them. And we've got to treat them on an individual basis. We have our documentary, Operation Resurrection, that is coming out to be released in February of 2013, and it is going to be relating the exact solutions to the traumatic brain injury in our veterans, the solutions for healthcare, education, and employment, the triumvirate, the three major things that give our warrior a future back here in our country. I'd invite you to take a look at the trailer. That's at operationresurrection.com. And then we have our Resurrecting Lives Foundation, which is the movement. And it is a grassroots movement to get everyone involved in the civilian world. The 99% of us who said, we'll go to the mall, we're not going to war, we're not going over there, we'll send this 1% over there and we'll clap for them when they return. But we've got to do more than clap for them. We've got to help them heal, because they are the most productive area of our society. They are our future leaders, and that is the charge that we at the Resurrecting Lives Foundation are giving. There is our phone number there and our website, and if you have any questions about what's going on with our military, or if we don't have the answers, we will get them to you. And I invite you all to come to our website, to contact us, and to let us know what's going on, because I want you all to join our movement. And in the words of General George S. Patton Jr., the famous World War II general, when it comes to taking care of our veterans and their families who are suffering from the global effects of traumatic brain injury, we are inviting you to lead, which I hope you all will do, or follow, or get out of our way. Because we are marching on to help the nearly 500,000 of our heroes returning from war. And the last, I'm going to hit you a little bit with something that's near and dear to your hearts, I know, which is the osteopathic oath. And what I find so important in that oath is that you are here as a physician, listening to the patient, and your main job is to instill hope. In so many of our warriors coming back, all hope is gone. Give them back that hope. Remind them that they're out of their brain, not out of their mind, and you are going to lead them to a new normal with their brain, and that you will make sure that they can have a future, and a productive future, back in the United States of America. And I want to thank you all today for your patience, for listening to this. Again, I look forward to hearing from any and all of you, if possible. And I look forward to us working together in the future to bring back our heroes. Thanks again.